Testing 1, 2, 3.
Okay, try it.
Testing 1, 2, 3.
Yes.
Okay. Great, good morning. We're going to actually start again. So I have the unique pleasure to announce our second webinar in our webinar series of the Cervical Cancer Free Coalition. In the webinar series today is part of our Provider Interventions to Increase HPV Vaccination in the United States webinar series. And the title is Understanding HPV Vaccination Successes in North Carolina. This actually webinar really started as a response to the MMWR data from the CDC that was released from the National Immunization Survey Teen, which showed that North Carolina was was one of a handful of states that actually showed dramatic increases in the HPV vaccine continuation and initiation. And so, for example, in North Carolina, from the period of 2013 to 2014, we saw an increase in the 3-dose completion of young females aged 13 to 17 from 33% to 54%. So we have a very exciting lineup today. Just as a reminder for those of you who were not attending the first webinar, that I'm going to give a quick introduction as each speaker is going to be presenting. And then I request that all participants please mute your phone if you're on the phone line. Many of you may not be on the phone line. You can actually get the actual microphone from your computer to actually be able to hear the webinar directly from the webinar link. But if you're on the go or not actually on the actual webinar link, you can call in as you know, but please put all your phones on mute because we can actually hear you if you don't have your phones on mute on the telephone line. So as you see on the right-hand side of the screen, there's a little box that we hope that you would please enter your email address, and so we can ensure that you can be put on our mailing list. And at the end of the webinar, we do have sufficient time for questions and answers, and Dr. Noel Brewer has kindly agreed to help us in terms of facilitating that question and answer series. So, and I will also just wanted to say that this webinar, for friends of yours or colleagues who would like to hear it later, we will have an archived version of this webinar on our Cervical Cancer Free Coalition, cervicalcancerfreecoalition.org website. So without further ado, again, please mute your microphones if you're on the telephone line. I have the real pleasure, and it's very exciting to introduce today Dr. Noel Brewer, who is an associate professor here at the Gilling School of Global Public Health in Chapel Hill. And he will be giving an overview on cervical cancer-free North Carolina. Thank you so much.
Hey there, I'm going to talk today on two topics. The first one is going to be about my work with Cervical Cancer Free North Carolina, a statewide coalition to reduce the rates of cervical cancer in our state. I'll also talk about physician training for efficiency recommendations near the end of the call. And we have a little bit of technical stuff on our end. I think we're ready to go. All right, so the slides are up. All right, so the first thing I want to do is to give a disclosure. I have received funding from various federal agencies that regulate HPV vaccine, as well as some manufacturers of the vaccine, including Merck and GlaxoSmithKline. In early work by Cervical Cancer Free North Carolina to help our state coordinate efforts and to understand what the opportunities are, we did some analyses and also looked at the literature to identify what the main causes of cervical cancer are. That was our first step. Then we did some analysis of the data, and then we also looked to our partners to try to understand what opportunities they saw and to coordinate opinions and create a report. So let me talk about that first piece, which is the Carolina framework. According to epidemiological data, of course, almost all, roughly speaking, 100% of HPV, of cervical cancers are due to HPV infections. And of course, that leads to an opportunity to provide HPV vaccine as a way to prevent these infections. The current version of HPV vaccine, HPV-9, will present up to 90% of oncogenic HPV infections that lead to cervical cancers. The second cause of cervical cancer cases is not screening, and most of those are people who have never been screened, and that's about 54% of cervical cancers are found among women who have not been screened or rarely been screened. Of course, regular Pap screening can help to address that. The piece is screening errors, where there are false negatives, and that can be addressed by HPV DNA testing. And then, of course, there's incomplete treatment, women who are not connected to follow-up care. That's more prevalent among minority women. So the next thing we did is we applied this framework to data from our state. We analyzed various counties on their cervical cancer prevention need based on high cervical cancer incidence and death, low rates of vaccination, and low rate screening. What we found is in the south central area around Cumberland County, there were high rates of cervical cancer, as well as high rates of cervical cancer prevention need, as well as in the northern, eastern region of the state, and a little bit out in the west. We shared this with our state partners, and these state partners who were at the state immunization branch, who were at the state screening branch, as well as various local agencies and non-governmental organizations. They have a lot of advice for each other and also for us in terms of what we can do to be more effective. I'm going to give you the advice they gave about HPV vaccination. Their recommendation was to encourage HPV vaccine providers to recommend HPV vaccine routinely and strongly. So in particular, providers should recommend HPV vaccine during all preventive care visits, especially when vaccinated for Tdap and meningitis, to also be offering HPV vaccine. Another one is to access training opportunities for increasing vaccination rates. There are CMEs that are available, and also some MOC, maintenance and certification opportunities. There are other organizations that the partners tasked with various tasks, including healthcare associations and other coalition members. That was their main recommendation, was around healthcare providers routinely recommending, but they also recommended reducing missed opportunities for vaccination. Well, the state health department could help to provide routine AFIX trainings that focus on adolescent vaccination, and we'll hear from Melissa Gilkey, who did some work on that, as well as the state immunization branch, who also has done extensive work in that area. In addition, community health agencies could expand in-reach by recruiting teams from other internal clinics. All providers, of course, could have greater use of the immunization registry. There's a statewide organization called Community Care of North Carolina that provides coordinated care for low-income residents, and using patient care alerts in their system could be particularly helpful. And the immunization registry for a while was not able to do reminder recall for the first HPV dose, and they've since addressed that issue. So that's just the highlights of the report. There's quite a bit more. So if you'd like to download the report, it's titled Cervical Cancer Prevention in North Carolina, Strengthening Health Programs and Systems. If you have the ability to write that down, that's fine. The report, though, the simplest way is to just Google cervical cancer Carolina. The first link is usually ours, and then you can, in the middle of the page, where it has the report and then the updated report from our statewide summit that had with all of our partners, as well as from the regional summit followed up with. The other thing you can do is you can use the link down below that says tinyurl.com/ccfn1, and that'll bring you there. Thank you very much.
Great, thank you very much, Noel. So I actually have the pleasure and to Melissa Gilkey. And Melissa is an assistant professor of population medicine at the Harvard Medical School in Cambridge. And she will be talking to us today about an evaluation of a North Carolina Quality Improvement Visits AFIX. And welcome, Dr. Gilkey. Glad to have you.
Great, thank you for having me. As you said, I'm going to share some findings from an evaluation we conducted at UNC a number of years ago now in partnership with our state's immunization branch. And together we wanted to assess the impact of the CDC's AFIX model on adolescent immunization, including HPV vaccination. Before I get started, though, let me take just a moment to acknowledge our study team, including Noel, who PI'd the study, as well as Amanda Dayton and Amy Grimshaw, who are our partners. at the Division of Public Health. APEX stands for Assessment, Feedback, Incentives, and Exchange, and it's a model of immunization quality improvement by the CDC. So APEX is based on the process of what's called assess feedback, which involves giving providers data on what percentage of their adolescents are immunized and then providing training to help them improve. CDC recommends that health departments provide APEX consultations to at least a quarter of all of their federally funded vaccine providers each year. And the process is already going on a very big level. Our team became interested in how we might be able to apply the APEX model, which up until that point had been used primarily for early childhood vaccination, to improve adolescent vaccination. To explore that question, we conducted a randomized controlled trial to assess the effectiveness of APEX consultations for increasing adolescent vaccine coverage. We also wanted to compare the effectiveness of two types of APEX consultation, one delivered in person in the traditional way and one delivered by webinar. We assigned 91 primary care clinics in our trial to receive one of three conditions: traditional APEX consultations delivered in person, APEX consultations delivered by webinar, or no intervention control. As the name suggests, in-person consultations were delivered on site. So Amanda Dayton from our immunization branch actually traveled to the clinics and met with clinicians face-to-face. Webinar consultations were interactive, and they were designed to provide the same thing in terms of content, but they were delivered online using Adobe Connect, so just like we're using now. And in terms of what the APEX consultations involved, each clinic in the intervention arms received a single quality improvement session that lasted between an hour and an hour and a half. The session was typically conducted with one person in the clinic, usually the nurse who served as the clinic's immunization coordinator. In terms of content, Amanda would begin the consultation by sharing feedback on what percentage of the clinic's adolescent patients had received each of the vaccines in the adolescent platform. And then she'd work with the clinician to assess the extent to which the clinic was using organizational policies and practices to support immunization. So these were things like using reminder recall systems. And then based on that assessment, Amanda provided training to the clinicians and helped them establish goals for improvement. So here you can see our main outcomes, which were assessed at 5-month follow-up. And this chart shows vaccine coverage changes by study arm for younger adolescents. So the bars represent the number of percentage points by which immunization coverage in each study arm improved for patients ages 11 to 12. So the first cluster of bars shows how coverage changed for Tdap, and we see that for adolescents in the control arm, coverage improved by about 4 percentage points, but for the two intervention arms, it improved by about 8 percentage points. So we found that APEX did have an impact on Tdap coverage, and we see a similar pattern for meningococcal vaccination. For HPV vaccine, we did find a statistically significant effect, but it was smaller, just 1.5 to 2 points over control. Our second study aim was to compare the each other, and as you can see in the figure, we didn't find evidence to suggest the two delivery modes differed. Actually, somewhat of a surprise. Webinar consultations really seem to impact vaccine coverage as much as traditional in-person visits. We were excited about these 5-month findings because they're in keeping with what prior research shows on early childhood APEX, but unfortunately an analysis we conducted of outcomes at 1 year suggested the improvements we saw at 5 months didn't last. So at 1 year, coverage for Tdap, meningococcal vaccine, and HPV vaccine initiation was about the same across the 3 study arms. In addition to our outcomes analysis, we also conducted a process evaluation, and here we can see a comparison of the two delivery modes on cost. We found that we were able to deliver webinar consultations at about 2/3 the cost of in-person ones. So about $100 versus $150 per clinic. And that was really good news because there may be some potential for real cost savings here. So those are the main findings of our pilot work, which left us with both optimism that APEX could work, but also really a desire to make it work better, especially for HPV vaccination. And toward that end, the UNC team is currently in the process of another RCT, this one funded by the Robert Wood Johnson Foundation, to develop an APEX consultation design with the explicit goal of raising HPV vaccination coverage. Now in the pilot, we're comparing in-person and webinar delivery, and we're partnering with state health departments in Washington, Michigan, and Illinois. So since our trial is ongoing, I unfortunately don't have findings to share with you with regard to the new study, but I will leave you with a sneak peek of our immunization report card, which is one of the materials we've designed to focus providers on the problem of low HPV vaccine coverage. And I'll also just conclude by saying the AFIX is an amazing opportunity in terms of existing infrastructure for quality improvement. There's really just nothing else like it. And our goal is to make it work better, especially for HPV. And the folks at DPH have also been working toward that goal, and we'll hear now more about that from Jenny and Beth. Thank you.
Thank you very much, Melissa.
Thank you very much, Melissa. Very much, Melissa. Very much, Melissa. Very much, Melissa.
So we've had some interference on the lines. To remind all of the speakers to please turn off any cell phones that they may have on, or put the cell phones in airplane mode, just so we can actually have not have any interference from telephone. So thank you very much, Melissa. Now we have to introduce Jenny Myers Meadows, who are here to join us from the North Carolina branch in Raleigh, and they'll be talking about quality improvement visits, AFIX. Welcome.
Thanks, Jennifer. All right, so we were going to talk to you a little bit about how we have targeted HPV through our work with AFIX and our VSC site visits. So Melissa talked to you a little bit about what AFIX is, but VSC site visits refers to the compliance visits that we conduct on our providers to ensure that they're following federal and state guidelines. So who conducts these visits in North Carolina? We have two different sets of staff that conduct compliance visits and another set of staff that conduct AFIX visits. We have approximately 1,200 providers that are enrolled in the VSC program in North Carolina, and these visits are conducted independently of each other, so they're not a joint visit. Half of the providers are seen for a site visit 1 year, and the remaining are targeted for AFIX. So every other year.
Jenny, are you able to mute your speaker?
Yes, is that better?
Yes, much better. Thank you very much.
Jennifer, can you hear me?
I can hear you perfectly now. Thank you.
Okay. What was going on here? So this kind of presented as a perfect opportunity for us to talk to providers about HPV, since we're in their office at least every other year, if not every year. So as an overview, there are two types of AFIX visits. We have a childhood visit and an adolescent visit. Both of these types of visits are prioritized based on their status in the VSC program, the number of children or adolescent clients that they serve, their practice level coverage, county level coverage, and also if their county happens to have a high rate of disease. We conduct all of these visits in person. We just view it as a perfect opportunity to have a one-on-one conversation with providers and staff. It seems like providers are more open to talking about barriers that they have and successes that they have. It allows us to better assess kind of the flow of immunizations in their practice and try to understand if there's a root cause for low rates. We also follow CDC methodology, like Melissa talked about too. So regardless of the type of AFIX visit, we always talk about HPV. We assess their coverage for 3 HPV at every visit, so including childhood visits and regardless of the number of adolescent patients that they serve. We review the ACIP schedule and recommendations, and specifically talking about the HPV vaccine and how that relates to the new HPV-9, if they have questions about that. We provide reminder recall training and use HPV vaccine as an example. CDC has also distributed several North Carolina specific HPV reports, so we've made that a mandatory requirement for our staff to review those. And we also have a lengthy discussion on missed opportunities. Our registry has the capability of assessing missed opportunities, So we can actually provide data on their patient population and show them when they have missed an opportunity to vaccinate against HPV. We talk about having a strong clinical recommendation and not singling out required vaccines versus HPV is just a recommendation. So that's a conversation we have at every visit. Adolescent AFIX actually started formally last year. We have always been involved with assessing the adolescent population, whether it be through community assessments or independent projects or our IPE project. But we actually just started this officially in the fall of last year with public and private providers. On this visit, we assessed for coverage for 1 Tdap, 1 meninge, 2 MMR, which was related to the high level of disease in the country, and then 3 HPV in the 13 to 18-year-old population. We compared their rates as a provider's office to that of the county, the state, the national rates from the NIS survey, and how those compare to the Healthy People 2020 goals. We talked about disease rates, which includes pertussis, cervical cancer, meningococcal disease. We obviously talked about missed opportunities. We talked about drop-off areas and areas that they're having trouble bringing patients in for. We talked about strategies and how they can work on some of those trouble areas. We talked about the HPV reports, where to find resources, and then we monitor their progress over the next 3 to 6 months. This graph kind of shows how our HPV coverage from our adolescent visits increased here. So this was probably about 40 to 50 that we're seeing for adolescent AFIX, and all of these were targeted the number of patients that they saw and their coverage levels. So they were kind of low to begin with, but overall, cumulatively, those rates increased over 7 percentage points. It's very encouraging to us. So how do we target these? How do we target HPV through VSC site visits? So something that Beth Meadows, who's our field services unit manager, is going to talk to you a little bit about.
Thanks, Jenny. So for our VSC site visits, these are compliance site visits that are a requirement of providers who are enrolled in the Vaccine for Children's program. So in other words, they receive state-supplied vaccine, and they have to go through these visits in order to remain in the program. Really, the purpose of these visits is for compliance issues, but indirectly, we hope to see increases in HPV vaccine uptake as a result of some of these visits. On the visits, we ensure that providers carry all vaccines appropriate for public and private patient populations, and this definitely includes HPV. We're making sure that ACIP recommended vaccines, including HPV, are offered and administered. A good example of that is HPV is recommended for boys now, so we still see some providers who may be only giving it to girls, so that's something we can address during this. We make sure that providers and their staff are aware of where to find resources on HPV as well as the other ACIP recommended vaccines. We check standing orders if they're in place, if that's appropriate for that setting. For example, all local health departments are required to have standing orders for their vaccine. We want to make sure that clinical staff are comfortable with advocating the HPV vaccine as a form of prevention, trying to stay away from HPV as a STD prevention. It truly is a vaccine. And if we're finding that providers are not giving HPV like they're supposed to and they're not following ACIP recommendations, we want to point out that it is a standard of care, just as it is to screen for depression or to do a vision screening. HPV recommendations for the vaccine is definitely a standard of care.
So we also try to target HPV through other types of VSC visits. One of those is our registry training. So part of that training includes reminder recall. So we always use HPV as an example for the adolescent population so they can see how to use that for other vaccines, not just childhood. We talk to them about how to run other client-based coverage reports. We also review their orders, their vaccine orders through us to make sure that they're ordering appropriately. So if they're ordering a lot more Tdap and meningococcal than they are HPV, we talk to them about that because all of those technically should be about the same. We also talk about this at inventory and storage-related visits. We always check out their inventory and compare that to the patient population that they serve to make sure that the levels are appropriate. We also have a couple of staff members that conduct middle school assessments, and that's a great opportunity for them to talk about Garrett's Law, which requires schools to distribute resources on HPV, as well as meningococcal and flu to parents. One of the biggest things that I think has helped our rates in North Carolina is just the collaboration that we have with so many other groups of people and our providers. I think it takes a group effort to make the progress that we have. So I wanted to point that out. It's not just one group. In sum, the lessons that we would like to relay out include just really trying to focus on getting patients back in for doses 2 and 3. That's really a big drop-off area. Our coverage for one dose is pretty decent. There's still a lot of room for improvement, but it's the dose number 2 and 3 that seem to have a lot of providers are having a lot of problems with. Don't segregate HPV when you're making vaccine recommendations to parents. They all need to be grouped together. Definitely don't forget about the boys. We're making a lot of progress with our girls, but our boys also need to be vaccinated as well. And just like Beth talked about, be sure to refer to the HPV vaccine as a form of cancer prevention and practice talking to hesitant parents about vaccinating their teens. We do that a lot here, and at our conferences, we kind of give examples of how to talk to parents that are unsure or don't understand that it is protecting against a form of cancer. It's not just a STD. So overall, I think those are probably the 4 takeaway lessons that we would want everybody to understand. At the bottom, we've included some resources about how to talk to parents and some key facts to keep. If you have any questions, let us know.
Thank you very much, Jenny and Beth. That was great. And we're going to head into the next presentation, which is by Joan Cates. So Joan, if you could please make sure that your speaker is off and then turn your mic on. And Joan will be speaking today about social marketing to promote preteen HPV vaccination. So welcome, Joan.
Thank you, Jennifer, and hi everyone. This segment is on using social marketing to promote HPV vaccination in preteens.
Joan, are you there?
Speaker off.
The green.
This one?
Yes.
Okay, can you hear me now?
Thank you.
Hello?
Yes, we can hear you. That's great. Thank you.
Can you hear me now?
Yes, I can hear you. Thank you so much.
Okay. Anyway, thanks again. Okay. So in North Carolina, we've conducted 2 social marketing campaigns, one to promote HPV vaccination for girls in 2009, and one to promote HPV vaccination for boys in 2012. So what is social marketing? Social marketing for public health means using business-type strategies considering product, in this case HPV vaccine, price, which is cost of vaccination, perceptions of safety and efficacy and access, promotion techniques for parents to get their children vaccinated. So, for example, radio essays, posters in community settings, and doctor's recommendations, and place, such as the doctor's office. UNC research and working in the 13-county South Central North Carolina area since 2007. County health directors in the region worried about high rates of cervical cancer and also worried that the most vulnerable would not seek vaccination, sought to promote HPV vaccination among girls. They wanted materials that were truly appropriate and targeted toward mothers as decision makers. Asked for help from us at UNC to develop these materials and conduct a marketing campaign to promote vaccination. We held focus groups and intercept interviews with mothers of girls ages 9 to 13 to find out what images and messages might motivate them to get their daughters vaccinated against HPV. They told us they wanted pictures of mothers and daughters close together and show racial and ethnic diversity. They wanted to emphasize the recommended age of 11 and 12 and cervical cancer prevention. They wanted details on safety, efficacy, and access, and that materials be in both English and Spanish. These are two of the posters we developed for the campaign. We also have brochures with similar images and text. We focused the campaign in 4 counties in the 13-county region and widely distributed posters and brochures in community locations and health practices. The campaign ran for the summer months in 2009. We found with evaluation surveys that mothers who were aware of the campaign were more likely to talk with a doctor, talk with their daughter, and talk to family and friends about HPV vaccination than were mothers who were not aware of the campaign. We also found that with evaluation surveys of providers that nearly all used brochures in conversations with parents, and 2/3 said the campaign influenced parents' decisions to vaccinate. When we examined the North Carolina Immunization Registry data, we saw that 2 of the 4 counties had higher rates of HPV vaccination initiation than the state average. In 2012, soon after HPV vaccination was recommended for routine use in 11 and 12-year-old boys, we conducted a social marketing campaign for boys in the same 13-county region and in all 13 counties. This time we compared preteen HPV vaccination outcomes with a control group of counties in another part of the state. This is a poster from our boys campaign that was developed and tested with formative research among parents of preteen boys. Through our research, we found that parents preferred images with parents and sons close together, images with multiple races and ethnicities, a message about the risk of the son getting HPV, and a message about protection from HPV disease. We also had companion brochures in English and Spanish. We looked at the immunization data after the campaign and found a boost again. The red line shows the intervention counties, and the black line is the control group, and the blue is the rest of the state. This translates to the probability of HPV vaccination for a boy ages 11 and 12 increased by 34% in the intervention counties relative to the control counties. So the lessons learned for success with social marketing to promote HPV vaccination in North Carolina is to get input of parents of preteen boys and girls on message design, to have willing providers to use our print materials developed with parents' input, to have strong public health support, which we had on the local, regional, and state level, and to use North Carolina Immunization Registry data to measure vaccination outcomes. So the final slide shows some of the partners that we worked with on these social marketing campaigns. And at this point, I will pass it back to Jennifer. Thank you very much.
Thank you very much, Joan, for excellent presentation and for keeping to time. So I have the distinct pleasure now to invite Elizabeth Hudgens, who's here as the Executive Director of the North Carolina Pediatric Society. And Elizabeth will be talking about North Carolina Pediatric Society HPV projects. Welcome, Elizabeth. So please make sure that when you speak to have your speaker muted while your microphone's on. Thank you, Elizabeth.
Great, thank you all. I appreciate this opportunity. Again, my name is Elizabeth Hudgens. My contact information is here. I'm Executive Director of the North Carolina Pediatric Society. Unlike a lot of the folks who presented today who have done big projects where they're doing a lot of work, ours is really more focused on connecting people with the great information and learning that other people have done. We are currently working on 2 HPV projects. One is wrapping up, one is about to begin. Both are focused on HPV completion as opposed to, say, initiation or something like that. And both, as I mentioned, are focused on ways to share the great work of others and link resources to make sure that pediatricians and other...
Elizabeth, are you able to possibly mute your microphone on your computer?
We have a grant from the American Academy of Pediatrics that's about increasing education and awareness. So we've done a variety of activities on this. We provided some in-person educational opportunities. We had Suzanne Buck present at a practice manager retreat in March, we had a very robust network of practice managers from pediatric practices around the state. And these are the folks who are really working on making the appointments and making sure the callbacks happen. Suzanne Buck talked about a variety of things, including how to use the NCIR system, which in addition to being effective, has the additional benefit of being free to practices. So there's a lot of reminder and call things out there, but to be able to link folks with such a great and cost-effective resource is really a great thing to get to do. Dr. Tamara Coyne-Beasley, whose work has been referenced several times, presented on communication strategies at our open forum in April. And Dr. Sharon Homestead, who was recommended by the CDC, presented at our August annual meeting, and that was to about 200 folks. And so really got from around the state. So we really got a nice widespread of people talking about this. We're also having some upcoming webinar learning opportunities. You can register at our website if the information's not up there yet, so keep coming back. On October 30th, Dr. Preeti Mackins from Team Health Connection in Charlotte will talk about practice pointers. They have a very high completion rate, and so she'll be talking about some of the strategies they've done to reach that. On November 30th, Jenny Myers, who you've already heard, but we'll be talking in more depth about the free reminder recall system we have with NCIR. And then on December 4th, Dr. Tamara Coyne-Beasley from UNC will be talking about communication strategies, some of which you've just heard, but to help decrease the barriers either the child or the parent or the doctor may have to make sure that kids get these vaccines that can help prevent cancer. We've also done different social media and other communications, reminding people about the HPV, especially with the changes in the school requirements and linking it with other shots like meningitis. Then we have an upcoming grant from the American Academy of Pediatrics. We've just received notice of, but we have not actually started the work. It's part of a broader project, a CDC initiative that the CDC is doing with AAP. That's then it's a complicated structure, but we're working with Virginia chapter on it, and it's using a quality improvement strategy to improve the HPV immunization rate. And we'll have about 10 people who, 10 practices from two. I'm sorry, thank you. Okay, I'm taking down my speakers. Is that better for folks? We'll have about 5 practices from North Carolina and 5 from Virginia who will be working with a consultant to do this work, and we'll be working with state partners like the immunization branch at the Division of Public Health. And we'll share those learning opportunities with others and the NCP's membership. And the goal is for participating practices to improve 33%. And the resources, some of it will be available to anyone. It's just available to members of the Pediatric Society. So the upcoming webinar is available to all. Again, stay tuned to our website. You can follow us on Twitter about great opportunities to link HPV and meningitis vaccines or whatever. Participation at the August 2016 meeting where we will be sharing learning on these will also be available to the general public. And then available to members only are regular updates, including reminders about upcoming events. We share new studies as they come out, things like that, and learning for upcoming HPV-QI work. You'll get invites and discounts to the in-person meeting, chance to network with your peers in the peer-to-peer learning, participation in practice managers discussion about the nuts and bolts of getting this work done and linking your practice manager with these resources, participation in an online community forum of topics of interest, including HPV if people elect for that, and select participation in the HPV-QI practice project. If you are a practice out there and really interested in this, please contact me, Elizabeth at NCP, and I'll be happy to get you additional information. Thank you.
you very much, Elizabeth. We've had a little bit of interference. I may be understating that. We've had quite a lot of interference with the presentations from Elizabeth and from Melissa, and for that I apologize. If during the question and answer period, both Elizabeth and Melissa could please make sure that they are not on the conference call line, because there seems to be some interference, or that you have your cell phones please off. That would be very helpful. So we have an opportunity now to have then again Dr. Noel Brewer to present on physician trainings for efficient HPV vaccine recommendations here from UNC Gillings School of Global Health. Thank you so much, Noel, for joining us.
Hi there, folks. Apologies. We've had some technical issues on our end, and I think that it's hard to sort out how much is internal to the system and how much is other people who are on the call. So we really do apologize for any difficulty you've had in hearing our presentations today. I'm going to switch now to my presentation on helping physicians recommend HPV vaccination. Physicians, of course, are our nation's backbone of HPV vaccine provision. There's some HPV vaccine provided in other settings, but it's really pretty much through physicians' offices, either by the physicians themselves or by the other clinical staff who are there. One of the challenges that we have, and I'm trying to forward the slide here, apologies. How do we forward it? It doesn't seem to want to forward. Oh, sneaky little arrow. There we go. Okay, thank you. Oops, now we got to back up. All right. Apologies, folks. All right, so one of the challenges we have is that HPV vaccination recommendation quality is low. These are data from a national sample of about 775 pediatricians and family physicians. And what we find is that about 40% of physicians who regularly provide HPV vaccine to adolescents are giving recommendations for males that are not timely. They routinely recommend it at age 13 or older. For females at age 26 or also at age 13 or older, 26% give recommendations that are not timely. With respect to endorsement, 27% of the physicians were giving recommendations that were also not strong, not fully endorsing the vaccine. 39% of physicians in this national study were giving recommendations that were inconsistent, meaning that they recommended strongly for some but not for others, and they tended to focus on high-risk groups, or groups at least that need to be at high risk, rather than all adolescents. And then finally, 40% of the physicians were giving recommendations that were not urgent, that did not indicate same-day vaccination. So overall, these are probably the best case scenario. The actual data may actually look just a little bit worse than this. We have work that we've been doing in North Carolina to try to address some of these challenges. We have a randomized controlled trial that is currently wrapping up where we were training physicians to give efficient recommendations, things that helped address some of the challenges that we'd heard about from physicians, but also to find a way to make recommendations more, to have recommendations happen in a way that took a little bit less time. So this recommendation approach has several characteristics to it. And again, I apologize, we have a bit of technical issues going on here, so it's a little hard for me to see the screen. Okay, so the first step of this three-step recommendation approach is to announce the child is due for 3 vaccines, and hopefully that will lead directly to vaccination. So a recommendation that is efficient could sound like this. I see here that Michael has turned 11 because he's 11, he's due for meningitis, HPV, and Tdap vaccines. We'll give those at the end of the visit. The key elements are that they noted the child's age, they announced the child was due for 3 vaccines and putting HPV vaccine in the middle, saying that you would vaccinate today, and then moving on with the visit. Those are all key elements to this first piece. However, some parents will be reluctant or have hesitation or maybe have concerns they express. Regardless of what they say, the second step, if it's necessary, is to ease their main concern. So physicians should ask, well, what is your main concern? And based on that, they can use the EASE acronym to address this main concern. The first part of EASE, the E, was elicit the main concern. The A is to acknowledge, the S is sharing your commitment, and E is educating on what the research shows. So the E would be to elicit that main concern that I mentioned. The A would be to acknowledge in a non-judgmental way, I can see why you'd have that concern, or I can see that you're concerned about this, without trying to battle the concern or invalidate it or otherwise be contrary with a parent. Then you would share your commitment, something like, because preventive care for kids beyond age is really important to me, I keep up to date on vaccination studies and I follow CDC guidelines. Finally, educating on what the research shows in whatever way you find appropriate. Now, the third step is to give a strong recommendation for HPV vaccine. And I'm going to give you an example that we offer to physicians. Kayla can get cervical cancer as an adult, but you can stop now. The HPV vaccine prevents most cervical cancers. I recommend Kayla get the HPV vaccine today. So there were 3 elements to that strong recommendation. The first was giving a motivational statement, and all the physicians listening on this call have some version of this that they use. You can also look at the CDC's Tips and Time Savers sheet that's available online that has excellent longer versions of some of these motivational statements, and you can take snippets out of there for shorter versions. So I gave a motivational statement, I ended with the phrase, I recommend, and I encourage vaccinating today. So those are the 3 elements of this approach. An announcement, easing the main concern, recommending HPV vaccine strongly. Now for some parents, this won't be enough. They're still going to be skeptical or wondering and needing more time to think about it. For those folks, bring them back to the clinic, ask them to return in 2 months, and ask your administrative staff or your nursing staff to help facilitate scheduling that next appointment. Now, as we've done these presentations throughout the state to over 20 clinics serving 30,000 adolescents, we've gotten some feedback. One of the pieces of feedback, one of the tips they've offered us, is to focus on cancer prevention, not on sex. If STIs come up, refocus the conversation on cancer prevention. Another thing we've heard is to treat HPV vaccine just the same as other required vaccines. In our state, in North Carolina, Tdap is required for school entry into 6th grade, and meningitis vaccine is now also required. One of the conversations that'll happen is a parent will say, well, which ones are the required vaccines? And then the physician takes well, these are required and this is just recommended, but I strongly recommend it. Don't even try that. Go directly for all 3 of them are strongly recommended and ignore the question about what's required. Go directly for we strongly recommend all 3 of these vaccines in our practice. So hopefully those approaches will help to lead to higher vaccination rates in your clinic in a way that's efficient and also highly respectful of parents. The final thing that I want to mention is that there are clear data showing in our state and in every state in the nation large summer peaks in vaccination. This red line on the slide shows the nation's average, and then the little squiggly lines represent every individual state. What this means is there's a peak in vaccination in the summer, and as a result, we should spend more time doing promotional activities in the summer and doing other kinds of changes that may be disruptive toward the fall or in the winter. So finally, in summary, the recommendations for practice are to recommend HPV vaccine at every visit for all children ages 11 to 12, to focus on cancer prevention, not sex, to treat HPV vaccine the same as other required vaccines, and then finally, to focus HPV vaccine promotion efforts in the spring and the summer, and systems changes in the fall and the winter. Thank you very much.
And I really so about 10 minutes now for us to have a question and answer period. So we hope that everyone can please use the question and answer box, which is on the right-hand side of the webinar screen, to please enter your questions in. So I actually have a few questions. I'm not sure, Noel, if you also have some questions for the speakers. Okay, great. So I think my first question actually goes out to Jenny and Beth Meadows. And one of the questions I have, and so if you could please, again, Jenny and Beth, thank you. One of the questions I have for you is, you talked about practicing, your script and parents. And I also talked about some script that he finds very effective, by which which he puts HPV in the middle of the list of these Ellison vaccines that are recommended. So what script are you actually recommending to use, or what is your script? How much does your script sound like the script that Noel had described in his presentation?
It's the exact same script. You know, he mentioned we don't want to segregate HPV, or as some people say, put it in a box. It's like
Beth,
they'll
can you
go in
please
and
mute your microphone? I can't hear him at all. Hello, Beth, can you please mute your speaker and then turn your microphone on? We can't hear you.
how about now, Jennifer? Is that okay?
Yeah, that's perfect, thank you.
All right. I'm not sure if you caught the last what I said or not, but it's the same script. So as Jenny mentioned earlier, we don't want providers to segregate HPV vaccine. HPV should be in the same conversation as meningococcal and Tdap. And sometimes what we'll find is that the provider will say Tdap and meningococcal are things that are recommended for this age group. Reasons why it's now a requirement for North Carolina students. Oh, and by the way, HPV is another vaccine. We need to all talk about them together, and that's really what we try to promote. We shouldn't segregate it.
At another point, Beth, in your presentation, you had talked about standing orders in appropriate settings. Could you talk a little bit more about what you consider to be those appropriate settings?
Yeah, that's practice specific. You know, local health departments are pretty much nurse driven. You know, they have a medical director, and some health departments don't even have physicians that are on site on a daily basis. So all of our health departments in North Carolina are required to have standing orders. We find that standing orders is just easier when a patient just kind of shows up, they walk in, you don't have to have a physician visit, you can follow your standing orders to vaccinate the patient, which is especially important for these adolescents who are coming in for second and third doses. Now, private practices, they operate differently. I mean, you may have RNs, you may have medical assistants, you may have other folks that are vaccinating, you may have their own rules and procedures for them. So it really depends on the setting. You know, we definitely promote standing orders, but private practices are not required to have standing orders. Most of them do not have standing orders. If a practice wanted to use a standing order, they wanted a template, the Immunization Action Coalition has some really great standing orders that they can just print off and have a medical physician sign it. And you know, that would be great if they could do those.
Great. Thank you very much. I think Noel has a question.
Hi, folks. Again, I can't overstate how complex the technical aspects are on our end, so we apologize if there's any discontinuity here. I have a question for the folks at the immunization branch in North Carolina. One is about what do you do to make scheduling these quality improvement visits go well? Scheduling them is one of the most complicated things, and helping other states with some advice on how you pull off having so many scheduled and getting these the providers to say yes. Can you give us any advice on scheduling and in making it appealing to them to want to have one of these quality improvement visits that we're calling AFIX visits?
Yeah, hey Noel. One of the things that our consultants do is like when they call these practices, so we give each of our consultants a list at the beginning of the year, and they're prioritized. There's some that are high priority, medium, and low. And when they call, one of the things that has worked well is telling the practice that they've been selected for an AFIX visit and make it sound like it's a very exciting thing. We've never really had a lot of pushback from, you know, going in there and doing our thing. They're usually pretty happy to have a visit and have extra help. So I really don't think that we've had too much of an issue with that. Does that answer your question?
It does. I know that some of what you do is you join AFIX visits and VFC visits. Is that currently your approach? I apologize because during that part of the talk I couldn't quite hear part of the slide. So are your quality improvement visits joined to the AFIX? I mean to the VFC quality visits?
Hey, Noel, this is Beth. No, we had them divorced several years ago. So we used to have those visits together, but we were really finding that it's hard to talk about increasing rates when your storage is horrific. You see what I'm saying? So there's so much that goes on with those compliance visits that it was kind of taken away from the AFIX process. So we've actually separated those several years ago, and we do not do them together.
Thank you. Yes, and that's my understanding of the CDC's recommendation is to separate VFC compliance visits that have a legal tone to them from AFIX visits, which are quality improvement visits that are meant to be supportive. So I'm really glad to hear you've separated those. I have one more question, then we can move on to other folks. For Garrett's Law, can you just say anything more about how you help to encourage folks to comply with Garrett's Law? Because that's an important way to get information out to parents, and some of our work has identified that only maybe 10 or 20% of schools were being effective at getting that out to parents in the way that they were getting the information on HPV vaccine.
Yeah, so that is a concern of ours as well. It's ultimately up to the schools to implement those laws, but how we promote it is during our middle school visits and some of our elementary school visits. So we do try to get information out while we're doing those visits, but of course, we don't see every school every year, so it really falls back on DPI to ensure that their school systems are following that.
So let's go on to Joan then. And Joan, we have a question for you. Can you tell people who are listening how they could get copies of your materials? Perhaps it could be through giving us your email address or a website. It would be really helpful for people to be able to get some of these great posters that you created, because they are terrific materials and they're really well tested.
Well, thanks very much, Noel. I appreciate the plug. We have some of the print materials left from the boys campaign. Most, but on the slide it's joancates@unc.edu. If people just email me, we'll be glad to distribute them as long as they last. But thanks again, Noel.
I have another quick question for you, Joan. If you're thinking about scaling up an intervention in the future in our state or another state in the United States, what are some of the things that you wouldn't do again, or you would absolutely do in terms of social marketing?
Well, it's interesting that you ask, because we're right in the middle of another NIH-funded study to take the lessons that we learned about communication and take them into the practice level. One of the challenges with social marketing media, like we did in the past, is that it's harder, especially nowadays in the days of media, and we had not used social media before. There's practically no way you can't be exposed to social media anymore. So we're taking the posters, the print posters, the brochures, and the communication points into the practices and studying whether it makes a difference. We have always had a piece in our communication that talks about sexually transmitted infections and talks with preteens. And so we're continuing with that and to understand the best way to do it in a sensitive and manner.
Thank you very much, Joan. And I see that we're wrapping up in terms of time now. Wanted to thank everyone who's joined the webinar, and thank you very much for your patience as we had a few technical difficulties in terms of the sound quality, and we'll work to improve that in the next one. We thank you very much for learning some really important lessons in North Carolina. And just to remind everyone that this webinar will be archived on the cervicalcancerfreecoalition.org website. And if you'd like to ask for any other additional information or have additional questions that we can follow up with you or get you any of the materials from this webinar, please feel free to email us at ccfa@unc.edu. Again, the email is ccfa@unc.edu. Thank you so much, and I'm really happy to follow up if you have any other additional questions or want more access to information. And we'll look forward to sending you out a link about the future of where this webinar will be archived. Thank you again, and everyone enjoy the rest of your Thursday. Thank you.